you, sir. I I'm going to speak about future of smile, but all the previous speakers have given a very beautiful talk on this, and Rupal ma'am had already given this talk. So I'll just go into very brief of what I want to discuss, so that I don't overlap. The points here is first is I go into these formats: the energy, cyclotorsion, circle, hypometropia, interoperative, and future. If I go into this energy setting here, we are coming lower and lower on the energy settings. You can see that electron microscopy completely changes as you go lower. And also there is different spot sizing, and the size of the spots also, if you change, the quality of vision actually becomes better. And this has been shown in this study that, your quality, the contrast, and all depends on your energy and also the way of spot sizing you're going to do. And this, according to this paper, and many people out here says, it's been told that this is one of the best energy setting with this spot sizing combination works very well as far as the quality of vision and the contrast is. So what I envision is more and more we're going to see different spot sizing and more lower energies to get the perfect outcome. Dr. Sri Ganesh and Sheetal Bar had given us beautiful insights into how they control the astigmatism, how they use their techniques. But what I see and what I've seen in a couple of new machines is it comes with a cyclotorsion control. So what the future of Smile is that it will have an inbuilt cyclotorsion control. You don't have to do a manual thing anymore. And I've personally been seen two of the machines which has it already. The Circle software, Gitangsha has explained. I'm not going to go deep into this. Basically, it's not just only on Circle. What I'm going to say is we'll have a lot of these unique softwares for rescue operations. For example, you'll have softwares in future where you can do smile on smile. Now we have to do a PRK if there's a regression. You'll have softwares to do retain lenticule. You'll have a software to change some parameters to make your flaps on the smile lenticule, on the smile post smile patient. So I think the options are going to be multiple, and that's what I want to say in this presentation. Hypermetropia, there are a lot of nice papers coming out now which does say that the quality of vision and stability of hypermetropia is as good as you see in LASIK, which is very good because one of the major challenges of hypermetropia is the regression. And these are all early papers, but if they're able to hold it for some more time, I think it will be the best thing we can see. Presbyopia, people are now, this is a monovision paper, but by Walter Sicando and his group, but there are a lot of work happening on can we do a presbyopic kind of ablation profile or lenticule change on the Smile platform. Intraoperative OCTs, not many machines now are looking at it, but I'm sure the future will have intraoperative OCTs. The reason we know we want intraoperative OCTs built is that, if you're doing a corneal-based procedures, I'm not very sure of this, but I know the latest machine of Zemer has an inbuilt OCT in it. And you can imagine you're doing a DALC or one of the corneal procedures, it will really have a huge impact in the procedure. This is the intraoperative OCT pictures which I've taken. This is not from the Smile, but in case you have a machine, you have to go to a different microscope and do it. And imagine having it in your own machine. That will be the way to go, because Smile anyway, this could be an upgrade, but this is a wish list, what I'm saying. Inlays, we've heard a lot of inlay work again by Dr. Sri Ganesh and Sheetal, and over time, I think many people across the world have grabbed this and they've been using it as an allogenic implants. And there are companies which makes these kind of implants, and I'm sure inlays are going to be a major areas of how we're going to treat this refractive procedures. And this is from Susan Jacob group about her Pearl technique of corneal inlays, what she's used. Let me just take into some amount of future what we've been working around Smile domain. We published this paper about predicting. Predicting is everything. Every time you see a COVID wave, first thing we'll look at is of all the IITs, every IIT will come out with their own predicting models. COVID has taught us a lot. One of the things it taught us is a good insight into immunology and good insight into prediction. This is an old paper 5 to 6 years back when we looked at predicting how much of biomechanical changes every procedure would happen. And you can see the dotted lines was our prediction. The sharp lines are the ones where we actually seen a change post-operatively. So we designed, this is the first simulation model in the world using the Corvus and the Pentacam. It's a software. It's a completely mathematical driven software and happens to be the first machine in the world, first software in the world. And 22 countries are already using it. And me and Dr. Prema started using it quite early. It was developed in our lab. What is important here is this will be part of your Pentacam or Oculus softwares in the future. That means that every time you feed in data, it will tell you, it uses a different mechanism of spring modeling. That's why it's in newtons and meters. It will tell you if you do a PRK, how much deformation. If it's on this side, beyond this green, that means there's a chance of ectasia. So that you can feed in your patient and you can feed in his data. The simulation model will tell you what is the simulation strength. That means this particular one will be part of your diagnostic tool. And this will tell you exactly which procedure I want to do and which procedure to avoid. And this is already past the beta testing, and Oculus is in your future softwares. This will be part of it. So it will be useful to see how you can decide SMILE or SMILE Extra or any other procedure. For example, if your predicted change in corneal stiffness post-operatively is more than around 15 or 20 newtons per meter, then you can look at a SMILE Extra. Or if it's less, you can even look at a PRK. So this is how it's going to change. This is how it's going to happen. We've been working also on the way the SMILE collagen works. This is the PSOCT. This is the normal, darker the blue is healthier collagen. What's interesting here is that in the SMILE, the pre-op and the post-op SMILE after 6 months is exactly the same collagen. Pre-op of PRK and PR post-PRK same. But look at LASIK. The darker blues have come down and you see less of darker blues. That means that collagen polarization has changed. That means it has completely reformatted itself, which you don't see. It's amazingly beautiful images. Why do you need it? These kind of machines are going to be part of how OCTs are future. So SMILE is not about technique, or SMILE is not about a surgery. SMILE is all about understanding how does your SMILE procedure behave on the cornea? Will it progress? Will it become ectatic? Will it change? And these machines tomorrow will be the future of how it picks up. There's also a big challenge about, in COVID times, you've seen the power of PCR. And we also need all this in our refractive surgery. So is SMILE. So we brought this kit. We've been talking about it, but now it's in the clinic. It is already manufactured. This is a kit. You just have to put a tear film and you can get all these inflammatory markers out here. Why it's important here is because you can help to identify many things which can be a potential issue of dryness, potential issue of neuropathic pain, collagen, haze, if you're doing a PRK, or any of these things can be done. And this is now not a research thing anymore. We have signed up with this company. This is the world leaders in manufacturing kits. They also manufacture all the pieces. It's in US. They manufacture the kits for many, many things. And these things can be brought out. And our aim is to keep this less than 1,000 rupees. And you can also look at the other VEGF and everything from the tiers. What I'm trying to say is all the new techniques on machines which are coming out with new ways of making the SMILE better. But what I see future is not just looking at a new machine or a laser. It's also about predicting how strong a procedure is, looking at the new ways of new imaging, like new OCTs or intra-op OCTs, and simple identification of unwanted dryness and other things which can create a huge havoc in your practice. I thank Dr. Kudlu sir and everybody out here for giving me this opportunity. Thank you.
Thank you, Dr. Rohit. In fact, I think I just wanted to ask you one quick question here that these kits already available in the market or yet to available?
We were supposed to do it last year, but this year, but the company which makes the kits, which builds that kit, was stuck with COVID. But next year, yes. And we have already using it in our lab, in our hospitals and some other places. It takes 45 minutes to 1 hour for the entire report.
So, do you really feel that okay, some patients really wants to undergo refractive procedure? Preoperatively, if you do this test, is it going to help the?
Absolutely, because it's not just for dry eye; it's about epithelial remodeling. If you're doing an hyperopia surgeries and if you want epithelium is aggressively remodeling, then you know that it's going to have an havoc with your outcomes. And Dr. Sikando, Professor Sikando has a question.
Just a question. Do you consider stuff in the future, like for every candidate for refractive surgery, or do you envision this as, for those that questionable, sometimes those are the things, the cases where you think, shall I do it? Perhaps I put an ICL instead. Or is it like, do you think it's affordable for everyone and it's going to be a standard, like with topography, and you do the immunotesting as well, or genetic testing?
Professor Sikando, if you ask me futuristically, in 10 years, everybody. In 5 years, maybe 50%. And maybe because the reason is, it's not only just for refractive surgery dryness. If you're doing a PRK, you have to really know whether it's got haze or not. There are markers in which I can tell you before you do a epithelial removal, what are the markers. So you can advise the patient or you can modulate your steroids. If you're doing a cataract surgery, a premium lens, will this patient come back to you 5 times in 1 month telling that he has pain or irritation? So you can pick this up early. It's just not for refractive surgery, it's for anything. And the same kit can pick up the VEGF in your tears and also predict the changes of your vascular status. Or it can even, my colleague has worked on VEGF in tears of an ROP baby. You can even, I'm also looking at VEGF, I'm looking at dopamine from the tears to predict the axial length of myopia. My colleague Jyoti has worked on it. So dopamine is a very important, I would say, hormone here, which if you more the dopamine, less is your axial length. That means that if your dopamine is good, and dopamine gets stimulated with sunlight, that's why the children need to be in sunlight to avoid myopia. If there are too many children in sunlight, it will reduce our practice 25 years from today, but by reducing the myopia. But sunlight and dopamine are a healthy marriage out there. And dopamine can also be big. That means you pick up any immunological parameters, you can just then add on. This kit can just keep looking at. Now we have 8 in it. I can make it 40 also. But the testing time is going to be the same. And we want to reduce it to 30 minutes. Now it takes 1 hour in the lab. But by the time the patient finishes everything and comes back, he's ready. But that is a beta testing.
Thank you, Rohit. Any comments from Professor Tithial? Tithial, sir?
Yeah, what to comment? Rohit always been a torchbearer in a research in this particular field, and we learned so much from his work. And I understand SMILE and any procedure, he rightly said, it is the procedure and the outcome is based on what modulation happening with the corneal tissue structures. That's going to modify the outcome of particular case. And whatever he's working on inflammatory markers for last almost a decade now, it's given us so many things to understand and look into. In fact, many institutions would struggle to have a similar, labs to get into that type of investigative research. So I really congratulate Rohit for a wonderful work, and I hope that he keeps working for this direction. We get a lot of information from his work.
Thank you, sir. I just want to tell one thing, because Dr. Krishna Prasad and was there for the presbyopia also. When you do a presbyopia, the most important thing is not the machine you use, how the epithelium heals. If the epithelium actually heals by 20 microns, your entire presbyopia goes for a toss. And what makes the epithelium go bad is your ocular surface and the inflammation. So imagine we always concentrate on machines, technologies, lasers, but we always, what Professor Titials perfectly said it, it's the healing which is more important than your lasers and energies. Your lasers and energies, even if the little way of body can heal, but if your healing becomes bad, everything messes up.
Thank you